powerful radiation therapy platform that combines the accuracy of intensity modulated radiation therapy with precise guidance to manage tumors effectively. We have a fully equipped medical oncology department that is capable of delivering cancer care solutions, namely cancer screening, cancer diagnosis, day care chemotherapy, targeted chemotherapy, and advanced treatment protocols like immunotherapy, targeted therapy, and hormone therapy. At HCG, we embrace precision medicine for successful cancer management. This helps us diagnose the patient's condition correctly and come up with the best treatment plan. Surgery is one of the major cancer treatment modalities. We have fully equipped state-of-the-art modular operation theaters to perform surgeries for both benign and malignant medical conditions. We perform organ-specific surgeries with excellent success rates. At HCG, we lead the way in adopting cutting-edge technologies, ensuring that our patients receive the best in medical advancements. Da Vinci X robotic surgery system is the newest addition to our arsenal of cancer-fighting technologies. And in a new era of surgical care, here we can prioritize disciplinary rehabilitation, pain, and palliative care units support a better quality of life for patients who are recovering from their treatment. We have an in-house pharmacy that is well stocked with both on-core and non-on-core medicines, and we also have a cafeteria that serves fresh and nutritious food throughout the day. With a winning combination of the latest treatment technologies, modern treatment approaches, and leading-edge clinical expertise, we at HCG Cancer Center aim to help patients win over cancer the right way, the first
Hello, hello, check. Hello, check. Hello, one, two, three. Hello, check. Check, check. Good evening, ladies and gentlemen. We will start our event within 10 minutes. May I request each and everyone, please be settled down. শুভ সন্ধ্যা সকলকে এবং আমরা আমাদের ইভেন্ট আর 10 মিনিটের মধ্যে স্টার্ট করতে চলেছি। আপনাদের সকলকে রিকোয়েস্ট করব আপনারা আপনাদের আসন গ্রহণ করুন। থ্যাংক ইউ। Everyone register yourself. We will start our event within 10 minutes. May I request each and everybody, please be settled down. Thank you. হ্যালো, হ্যালো, চেক। হ্যালো, চেক। হ্যালো, 1 2 3। হ্যালো, চেক। আপনাদের সকলকে অনুরোধ করছি আর 10 মিনিটের জন্য ওয়েট করার জন্য, বিকজ আমরা আমাদের মেইন ইভেন্ট আর কিছুক্ষণের মধ্যেই স্টার্ট করতে চলেছি। That is keep hello, check. Good evening, ladies and gentlemen, all the doctors, estimate guests, and pioneer of medical excellence. A very warm welcome to all of you to Kolkata. We are gathered here today. Yes, we are gathered here today. We are not just witnessing the revolution in oncology. We are part of it with cutting edge research, innovation, treatments, and collaborative efforts. Tonight, theme is not just a title, but vision for the future, decoding the future of cancer care, harnessing the next generation intelligence to transform the patient outcome. And in the rapidly, yes, right now we have honored to over 180 medical professionals in this room, including the professionals in this room and ACG own specialist, 150 senior oncologists. Thank you so much, everyone, for being here. Please put your hands together. एक बार खुद के लिए जोरदार तालियां हो जाए, please, everybody. As Welly said that the angel, yes, the angel on earth is the medical professionals. And thank you so much. Thank you, each one of you, what you do. And yes, your presence here today signified the collective commitment to one imperative goal and delivering the right treatment the first time. As we settle into this evening of clinical excellence, it is important to recognize the institution that makes such innovation possible right here in the city of joy. ACG Cancer Center, Kolkata is not just a hospital, it is a beacon of hope for Eastern and Northeastern India. So please, a big round of applause for ACG. The big round of applause, everybody. थैंक यू सो मच एंड यस हम सभी लोग बहुत देर से बैठे हुए थे सो कैन आई एवरी वन जॉइन फॉर द क्लैपिंग बट द क्लैपिंग इन डिफरेंट वे सो you can follow me just for a second, okay? So everybody just एक हाथ ऐसे करिए please, everyone, all the doctors are, yes, and now tap one finger, you can tap two, two, then three, four, five, and the round of applause, everybody. And ladies and gentlemen, we have Spain to the decoding the complexity of future. But the future of the cancer care is not just about the data or technology. It is about the collective light we bring to the darkness of the disease. And for that, can I everybody take off your phone and open your flashlight? Everyone. अब सभी लोग अपने फोन की फ्लैशलाइट थोड़ा ऑन कीजिए प्लीज एवरीवन प्लीज পিছনে যারা আছেন সবাইকে রিকোয়েস্ট করব all of you just show your flashlight. Can I have the music please? And everybody please stand for a second. And this is dedicated to all our patients. Everyone just right and left, we are moving. And yes, just look at the room. The single line represents the commitment, contribution, and hope. Together, we are not just watching the future, we are lighting off towards it. And let us our promise to never stop decoding, never stop fighting, and never stop caring. Everybody, a big round of applause. Thank you so much. Thank you so much. And yes, let me introduce myself. I am Anka Sukanya and I am Suktador for this beautiful evening. And now, yes, all the doctors, all the guests, it is my privilege to request you to join Dr. Manish Mattu, Executive Director and CEO, ACG, on stage for welcome address. Everyone, please put your hands together for. Thank you, sir.
Good evening. Yeah. Warm greetings to my colleagues, senior clinicians who have come here on a busy day, clinicians, my friends from the medical fraternity, and my colleagues from HCG Kolkata. HCG Kolkata started in 2018, as a dedicated, comprehensive cancer care center, and we've been around for 8 years now. But it gives me immense pride to be here on behalf of HCG Kolkata. In a city which is known for its intellect, strength, compassion, and these are the very qualities that drive comprehensive cancer care in a very progressive fashion. HCG, or Healthcare Global as it is known, stands as India's largest cancer care hospital network with about 26 comprehensive cancer care facilities across 18 cities, about 40 linacs, some of the most advanced technology that we have in our hospitals, supported by a robust team of over 400 oncologists, delivering multidisciplinary, multimodality expertise across our hospitals in the country. In the last 5 years, alone, we have treated over 10 lakh patients, and behind every number is a life transformed and a family supported. HCG was built on a simple but powerful belief that world class cancer care should not be limited just to metros, but to tier 2, tier 3 cities as well. That vision shaped our expansion across India, bringing comprehensive cancer care closer to home for millions of patients. Since our inception, HCG has been recognized as the pioneer in identifying and adopting latest treatment technologies like CyberKnife, Ethos, adaptive radiotherapy, Redizact, Tomotherapy Edge, and more. In addition to this, we have also embraced several unique and patient focused treatment approaches like robotics, precision diagnostics, molecular profiling, bone marrow transplants, CAR T cell therapies, high end immunotherapies, and these have revolutionized cancer care in India. These innovations have not only improved treatment outcomes for our patients but have also enhanced their quality of life. And today, as we speak, we boast of the lowest mortality rate among cancer patients in the country. And that's something we are all extremely proud of. And this happened because of dedicated, focused factory approach over the last nearly 3 decades of our existence. Technology, however, is only powerful when guided by compassion and expertise. At HCG, multidisciplinary tumor boards, evidence based protocols, and patient centered care models ensure that every patient receives the right treatment the very first time. I'm very proud to share with you that we are transforming cancer care in the country, one center at a time, one city at a time. And today, as we want to reinforce our national stance, think cancer care, think HCG. Through this, we are articulating our commitment to be the most trusted destination for cancer care in India. Behind this wonderful and powerful journey stands a visionary leader whose dream changed the way we see, understand, and treat cancer today. Dr. B.S. Ajaikumar is not only a pioneering oncologist, but also a true docpreneur. After completing his medical education in India, he trained in oncology in the United States in the prestigious MD Anderson Cancer Center. While building a successful career in America, he founded a not-for-profit organization, a not-for-profit cancer hospital in Mysore in 1989. Yet his larger dream was to bring global standards of cancer care back home to India. In 2003, he returned to India with a clear mission to build a world class, accessible, and affordable cancer care network, and he did it. He envisioned the hub and spoke model, which has been globally recognized by Harvard Business Review for making cancer care accessible and affordable through high quality care for people from across all walks of life in India. Through this approach, he has built a strong ecosystem of integrated and comprehensive cancer care across India. His philosophy was clear then, and it is even more relevant today. There is only one way to treat cancer the right way, the first time. With over 4 decades of experience, he has combined clinical excellence with social commitment and entrepreneurial vision to reshape oncology in India. It is now my privilege to invite to the dais the visionary behind this transformation, the founder and chairman of Healthcare Global Enterprises Limited, Dr. B.S. Ajaikumar. Sir, can I request you to come here on the stage and address the gathering?
Hello. Okay, now we are moving forward to the lamp lighting ceremony, and as we gather to mark the beginning of this event, it is time to invoke the light of knowledge, wisdom. Please join me for the lamp lighting ceremony. And for the lamp lighting ceremonies, Ajay sir is there, Mani sir is there, but can I have on stage the Rupali Basu, Dr. Rupali Basu, the Regional Business Head, East and APACG. Please put your hands together for her. And may I call on stage Mr. Gurvinder Singh, Chief Operating Officer for the lamp lighting ceremony. And can I have on stage Dr. Naveen Nagar and Dr. Bhattacharji. Everyone, please put your hands together. And now we are going for the lamp lighting ceremony. Shubham Kariti Kalyanam Agradhana Sampada Sattubuddhi Vinashaya Dikpujati Namastade. Everyone, please put your hands together. Thank you so much. And now, hello. We are moving forward to the scientific session by Dr. Ajaikumar, and with the next the panel discussion also there. So
You do one thing, put the number of chairs. Once I finish the first part, I'll call them, ask them question, one by one they'll come here. Okay? Okay. Thank you.
okay, after scientific session, we will moving forward to the panel discussion. Over to you, sir. Thank you.
Good evening, everyone. Thank you, Manish, for the introduction. And I would like to start off by saying Kolkata has always been a special place for me. I remember coming here several times. Today, as I was going through the city center, I remember all the buildings I visited to put up the center here. and what we all went through, because I was very passionate about doing here something. Dr. Bhattacharya is here. We came together so many times because somehow I felt Kolkata, the people, their passion, the way the culture, it really fits into HCG culture. Finally, we were able to start our cancer center here. And what I would like to do today is take you to a little bit of a journey, like we talk about decoding the future. How cancer care has really evolved. What has been in my 50 years of cancer care, if somebody asks me with 50 years having trained in one of the biggest centers in the world, you must be an expert. I say definitely not. Today, I don't think anybody can claim to be an expert in oncology. Why? That why is very important in managing any cancer. Maybe for any disease, but particularly for cancer, because we go by certain, as you know, in the long term, in my 50 years, cancer care was considered one of the most difficult. Anybody with cancer, some of you have experienced, would say they must be halfway down. They're finished, they're done. Particularly when you say the advanced cancer, stage 4 means khatam ho gaya, come in, complete. Patient would also think my life is over. Why should I take treatment? And then we started using terminologies like you are a stage 4. What happens to the patient when you tell you are a stage 4? What is stage 3? Means gone. And you would say palliative care. What does palliative care mean? Somehow I'm trying to keep you alive. You know you're going to leave soon. And we ourselves as oncologists get a great disservice because diabetologists don't say palliative care. Diabetes is not cured, but they don't say. Management of hypertension, people don't say you are in palliative care. But oncologists were the first one. They write, I started palliative care to the patient. So these terminologies and the society also, you can have a politician talking about certain things, or somebody, corruption is the cancer of the society. So we use cancer in such a detrimental way. The patient and families who have cancer, they become negative. Negativism breeds negativism. So in all my years, what I have seen practicing in US for 25 years, coming and starting HCG, was the most difficult task in managing cancer patients have been the society's approach. You call a cancer victim, we used to say. Cancer survivors, wow, he has survived the cancer. See, these kind of terminologies, in my view, these are personal views, have caused a lot of damage. Even today, when we see patients, you will see on some of the slides I'm going to show how advanced cases are treated. Today, for example, many diseases with advanced cancer, they may have disease let us say, from the breast, it might have spread to liver, lung, brain, or lung disease, lung cancer, which was one of the most difficult cancers to treat. 9 months survival, 11, 12 months. Now we are saying 5 years, 6 years, even with brain metastasis. Still, they are called advanced disease metastatic. So we have to, instead of saying stage 4, all of that, we should say where the disease is. In my own clinic on Tuesdays, which is advanced and recurrent tumors, we always talk about to the patient, your disease has spread from the lung to liver or brain. This is the scan showing. This is what the treatment will be. So terminologies have to be redone. And that is part of how we transform decode it, how we approach cancer care in the future. Cancer has to be approached as a chronic disease. Unless we approach cancer care as a chronic disease, we will never win the war on cancer. And why it is so important, like Dr. Manish said, first time right treatment is important. Because that is, the cancer is relentless. It is very unforgiving. And we talk about India in my journey in early 2000, when I was trying to go for linear accelerators. The common perception was India cannot afford high technology. But cancer doesn't know from low technology and high technology. Cancer doesn't spare poor people and say, it's okay, you're poor, I will not attack you. It attacks everyone. So everybody deserves the same treatment, whether rich or poor. It doesn't matter. How do we bring about uniformity of care? For example, you see a patient, it could be pediatric, it could be a young girl. Let us say, my own experience. Recently, I saw a patient who was from one of our tier 2 secondary in Vijayawada. They are given chemotherapy for breast cancer, 28-year-old breast patient. And 2 years later, patient had extensive disease. So when we did the audit, we asked, why didn't you give Herceptin? Because he was HER2 positive. The answer was the system did not allow the scheme. Tell me, my colleagues, who is responsible for this? Is the patient responsible that they were born to a lower socioeconomic group? Or is the hospital responsible for not having crossed the barriers and somehow made it possible, somehow raised the funds for it? Or is the system responsible for denying Herceptin in the scheme because it's too expensive, the drug? Which stakeholder is responsible? We have to reflect. We are all responsible, morally, ethically, for having denied a certain drug which could have been curative for the patient. We have to reflect, we have to introspect on all of this to come up with a solution. In India, there is a solution. What is the solution? We all talked. There is Niti Aayog, there is this, there is finance department. We have all done our things in bringing universal health care. So we come with a card. Everybody gets the same treatment. Even a porter in a railway station, his family, a person coming with a big Mercedes Benz, all should get the same treatment. Equality of care is so important for this country today. It is a right of everybody to get same care. Schemes are there, but they are not providing that equality. For example, when you say you do certain esophagectomy, lot of things I'm talking about in general, I give you 25,000 to do, people cut corners. They may not do right. When the recurrence happens, oh, it is cancer. Unfortunately, cancer cannot defend and say, hey, you did a peaceful job. That is why I've come back. The cancer can't say that. So we get away saying biology of cancer. That. So when the margins are not clear, when we do major operation, we have evidence to show when the margins are not clear, when you don't do frozen section, the recurrence rate is almost close to 100%. And who takes the blame for it? Not the surgeon who operates with close margin. It's the cancer which takes blame. Cancer has recurred. Radiation is given. Certain doses are not rightly given to the area of focus. Boost is not given. Patient recurs. So what we have to do is we have to audit. We in HCG, I'm very fortunate to have 400 oncologists, centers of excellence. We audit all cases and see what happened here and learn from it. We have a recurrence clinic, we have a mortality clinic. Every Tuesday, a tumor board, all 400 doctors have to participate, and we look at it in terms of audit. Dr. Bhattacharya is there, he and his team creates the data. We even have an AI team, data team to create algorithms on that. Why did the recurrence happen? What happened? What is the learning curve here? So we have to go deep into it. And as a chairman and founder, I will also say one thing. Today, focused factory approach is very important. HCG can become, most of our HCG centers, particularly our center of excellence, have everything. Cardiac cath, MRIs, high-end, and technology, robotic, everything. All of them can become overnight multi-speciality. Why is it we have not done multi-speciality? And by the way, we can also earn more. We can have better earnings, better margins. Why? Because we are specialists in cancer care. We know how to do cancer. For example, on a lighter note, you go to a restaurant, where a restaurant in Kolkata, where it offers your Bengali food, dosa, pizza, dokla, everything. Can it be very good, extraordinary? It can be average, maybe a little bit above average, but it cannot be. But if you go only to a specialized, only Bengali food, only subspeciality, in South India, only dosa, or you go to only pizza place, chances are they are much better. That is what HCG is. We are specialists only in oncology, and we know even intensive care, onco-intensive care management, pulmonologist, oncopulmonary management, cardiology, oncocardia management. We are experts in making sure the data speaks for it. When you look at our ICU, how many people come out? Majority come out of ICU. Right now, I have a patient who came in with literally no blood pressure in ICU and had a septic shock with a blood count of 400. All the efforts were put. Day 3, I got a note just now, our blood pressure is back to normal, no adrenaline support, no support system, urinating well, getting out of it. And we audit. Anyone with this kind of neutropenia sepsis dies in HCG, they are automatically audited. Whereas it is, the death rate is very high, but not in HCG. Mortality post-op. Any death within 72 hours is audited. So much so, majority of the centers now, zero mortality from operation, 72. So how does a patient feel when they come to the center like that? Man, this is the center. That is what we have to create. And we have to be trend setters for others to follow. Gone are the days when we used to say, oncology, no, it is okay. Cancer patient died, cancer patients are supposed to die. No, the quality of care, the, the way the nurses, the paramedical staff, the doctors, the intensivists, the genomics people, pathologists, everybody, radiologists have to come together for a decision making on the patient is imperative. Gone are the days of 15 minutes prescription. Oh, you have cancer of the breast. You treated with this drug. Now you have a recurrence. Protocol NCAN, second line, lagao. Okay, you failed second line, third line. That is not the way to treat. First, we have to understand why the patient failed. Why? Suppose I have two, let us say, breast cancer patients or two head and neck tongue cancer patients. Same stage, same pathology, squamous cell carcinoma or adenocarcinoma. Markers are same. Why is it one person responding? Why not another one? For example, we give a drug called HER2 positive drug called Herceptin. Standard drug. Everybody gets TCH therapy, HER2 positive. But do we know 40% of them fail? Because in that genomics in them, there is a PIK3, if there is mutation, it blocks Herceptin effect. Because it blocks Herceptin effect, unless you give an unblocker, Herceptin will not work. So you are unnecessarily giving treatment to 40% of the patients. Similarly, there are number of cases and head and neck cases. A tongue cancer comes with, let us say, large lesion, you call it T3, T4, goes to the surgeon. What does the surgeon do? I want to operate. Then we will think of radiation. The patient asks, Sir, what is the recurrence rate? Because you come in stage 3, 4, 60, 70% will recur. What to do? Still I have to do. Patient trust the doctor, get it done. Tell me, whatever the protocol is, are we justified in giving this kind of a treatment when there's high recurrence? Are we? We are not. That is why I conclude part of this saying, we cannot be in oncology. We cannot be community practitioners. Particularly when you have HCG as a dedicated cancer center, we have to be researchers, we have to be academicians, all things together. We are not an industry. We are a comprehensive cancer care provider with data, with research and academics to make sure it is not just from bed to bench, from bench to bedside for the same patient. That is the ultimate cancer treatment. That is precision. Precision means not just patient. Like I am Ajaikumar. If I have cancer, what is right treatment for Ajaikumar? That is where we have to do the treatment. And I'll explain to you in my patient slides why that is. Because we have to become failures or stepping stones. Any cancer patient who does not respond or who has a recurrence is a learning curve for that. Is a data. Why did this patient fail? What is the genomics? What is the mutation? How it has changed? What is the proteomics? Does the gene which shows mutation have enough protein, and is because of that lack of protein did it happen? So we have established a mass spectroscopy in HCG. Under that, we can make out now very soon is who will respond to mutation or not. If they don't have enough protein, they may not respond. And there is transcriptomics, spatial. What does spatial mean? Heterogeneity of cancer. For example, if you look at a cancer tissue, there may be certain mutations in one place, different mutation. When you do a biopsy, you're doing biopsy in one area, but you're not doing biopsy of the entire area. So you are not able to know what is happening in the other areas. So how do we know? Should we do multiple biopsies? When a recurrence happens, repeat biopsy we should do. And SUV on the nuclear scan, what is it? Different SUV activity, what does it tell us? All I am saying is, it is complex. Every 90 days, oncology is changing. So that is why it requires multidisciplinary team, organ-specific team, people spending time in that specialty all the time, understanding. I think then only we can win the war on cancer. In this, when I go back to my MD Anderson days, 1976, 77, at that time itself, people realized doctors used to be there in the day morning. Dr. Evans, he was there. One day I went to look at Dr. Evans. Where is he? I had to discuss a patient. He said he is on the 7th floor. I said, what is he doing on the 7th floor? You go and find out. I went. He was in his immunology lab doing research about the patient. That we lack today. And that is one thing we have to develop. Clinicians becoming researchers. Clinician understanding the story behind the story. Publications, data collection, learning. And that is mostly lacking today. And that is one of the primary things of HCG. Today we are starting CAR-T programs. We will be in organoids lab we have. We have worked with great scientists to develop this. Unless we do all this, and comprehensive cancer, which we do everything and fund this. HCG has a funding. Right now we fund 10 crores a year for our research. But I hope one day it will become 100 crores, because that is the type we need to draw people from all over the world, develop programs so that research becomes a very integral part of how we manage cancer. Bedside to bench to bedside for the same patient. In the past, we used to say, for future patient, this research. No, future is now. We have to do it for this patient. So I will show you some of the slides and we'll discuss. I will also call on some of our doctors who are here. I want to, maybe we can have a chair here. is here. I would call the doctors here as we discuss. Dr. Gaurav Agarwal, uro-oncologist, is here. Doctor, please come. Dr. Abhijit Das, radiation oncologist. Dr. Mandal, medical oncologist. We have Dr. Arjit Vishnu, hematology. Dr. Usha Rani, gynec oncologist. Dr. Jyoti Gupta, breast oncologist. Dr. Parvaz, surgical oncologist. And Dr. Segal, surgical oncologist, GI. Good. So thanks for here. I will be, as I show the slides and all, I will be throwing questions at them. We will have an interactive. And if anybody has a pertinent question, please raise your hand because it's important to have a meaningful discussion. So here, what I will do now is, of course, this is my own journey, like Manish mentioned, how, certain ideas come up as an entrepreneur, what you want to do. As I traveled across India in 1980s, I saw cobalt, I saw this. I say, what a wide gap between the West and here. Canadian government was producing cobalt only for so-called developing countries. Not a single Canadian was getting it. When I asked our people why, what to do? Man, it is treating more normal organs than tumor. What to do? We are a poor country. They even produce barbitrons. So, those were the days, difficult days to justify linear accelerator, not only in Bangalore or Mumbai, but we went to Ranchi, we went to Cuttack, we went to, Shumaga, all areas, tier 2, tier 3 cities, Ahmedabad, Baroda, everywhere, and we took a risk to putting these things. And a lot of things we learned. One of the things I learned was India can definitely put linear accelerators. India can definitely, the perception that we are poor is not correct. It's a misconception. If we make up our mind, we can really, we may not be rich, but we can achieve the goals of the rich by cross subsidy and other things. I think that is the thing I learned, how technology, and we became a trendsetters. Now, nobody talks about cobalt. Everything is about linear accelerator. And now we have gone to the other extreme. Let us put it, Bangalore has 42 linear accelerator. So it is other extreme because of what has happened. So, so what I want to show is some case studies and understanding the disease, what happens here. One of the things, Dr. Mandal, I'll ask you, you are the medical oncologist. How has the management of cancer has changed? Because we have a patient here who came in with, exon 19 deletion, had not only lung disease, but metastasis in the brain. And when we look at that time when we treated, we decided normally we do radiation to the brain when they have brain metastasis. We said no. And we did osimertinib only. And if you look at it from 2023, 3 years later, patient is disease free. What does it tell us about future of management of this kind of advanced lung cancer? What does it tell us? What is the future? That's not working. What is check.
Sir, basically this patient metastatic disease with brain mets. So with the advent of our advanced technology, where we are now more focused on the oncogenic driver mutation. So as our the science is progressing, more molecules are coming to the fields. To in stage 4 cases, we give them good survival. Recently, that EGFR mutation positive, we have our patients also in FLORA2 study where osimertinib and chemotherapy that shows good brain penetration.
But
And
this patient did only good on osimertinib, 3
yes,
years. So, what I want to tell you is we should collect our Indian data. We
yes,
should look at it. So we should not be followers we should also be leaders. How do we take this brain metastasis, people living for 3 years, disease free? So, yes, there are protocols we also try to follow, but can we create our own protocols?
Yes, we can have our real world data for the series of cases so that we can also produce that what we have done in these genetic mutation studies and give the good
So,
survival.
yeah. So, what I want to say is each of us should become a researcher. No? Each case should be go into bucketing to say this is what we want. Is it possible India, all of us can in HCG can become researchers? Is it possible? What prevents us from becoming researchers?
Yes, I think, sir, if the genetic study that are ensuing, that should be made keep more cost effective, so that every startup of the patient can use it.
But
And
doctor, we spend 1 lakh for immunotherapy. We can't spend 65,000 for genetic testing. Why? What is the mind block? Can we unblock that mind? Is the question. Huh?
I
So
think
I think we have to start thinking on those lines. If we have to become leaders in the world, we are all great doctors, very good. To do a DN or DNB in medical oncology is not easy. But somehow, what I want to tell you is when you look at these cases, they are not anecdotal. They are not anomaly. They are steady for us. So, in looking at this case, what we as HCG should do, which I'm sure you do, you treat them, like you said, chemotherapy and all. Can we take the treatment response to a different level, documenting it, creating algorithms? That is what I hope we can do as we move forward. Okay. So this patient, by the way, is doing extraordinarily well. It could be because of this exon 19 deletion. But when you do normal genetic sequence, you may not get a lot of information. So what we do in HCG is complete 500 gene sequencing. So we will see other blockers, other areas to see what is the right treatment, and particularly when they develop resistance. But this patient also at some point, Dr. Mandal, will develop resistance. We need to identify, do CTC, liquid biopsy, and look at the what happens to this exon 19 deletion. Does it go down and start coming back up through the blood test? And at that point, we can intervene to see change the therapy. So this is what we would look at in future. And this is the showing the scan of this patient, how they have completely responded. Now there is actually no evidence of disease.
another thing, sir, I just want to
Yeah,
add that
please feel free.
liquid biopsy ctDNA we are coming now. We have the ensuing data in colon cancer. So suppose in stage 4 patients who are on therapy, those who are getting good response, we can side by side also can do ctDNA study, so
Yes,
that in the future, if there is any relapse of the disease, we can early detect it
correct.
and can prevent those from preventing, so that we can early intervene and prevent from the further. When actually right now we are detecting at the progression, so we can hold that disease at beyond before progression.
Yeah.
So that is my
I
thought
am
in
all for
ctDNA.
ctDNA, CTC. We've done. I think as a group of HCG, we should come because we see 120,000 new patients a year. We don't have dearth of patients. We just the documenting and coming up with new protocols and all is what we need. Okay. Now, so this is what it is. This is the second patient who had a adnexal mass with ascites and treated as a carcinoma of the ovary in November 24. And she had a negative BRCA results, and it showed that HRD status was negative. With all this, I will go back to the next slide here. Course in the HCG, we circulating tumor swells was 0. Patient underwent surgery with HIPEC and chemotherapy, and CA125 closely monitoring. And one of the things we did for this patient, based on the certain stage she was in, as you can see here, pre-treatment CA125 was 3,500. When you see a high CA, irrespective what the PET scan shows or anything, you have to classify them as a high risk recurrence because the numbers are very high. You cannot go by just PET scan staging, stage This is stage 2 or 3. So this was important for us. We looked at that as a team. Then one of the things we did, I don't know, is it the same? Yeah, sorry, the first patient, yeah. One of the important things we did was we put in an intraperitoneal therapy. We said IP is important because when you give systemic chemotherapy, we don't know. Suppose I give you 100 milligrams, how much is really going into the peritoneum, scar tissue, surgery. So we have to overcome by directly giving into the abdomen. That is what we did for this patient. And the CA125 dropped to 67 and back to normal 37. So clearly indicating that she went into complete reports. And we kind of published this in the annals of clinical case reports, showing that a high end stage, stage 3, she was very high. 5 years down the road, she's living without disease. And this is because of the coordinated work between the surgeons, medical oncologists, everyone. And here I will ask Dr. Usha Rani, your gynec oncologist, young, aggressive. What do you think of this, and how? What do you think of this outcome, and how? What is the learning curve here, and how will you think we should manage these cases in the future? They come to you. Not coming.
Sir, as she's a advanced case, advanced high-grade carcinoma ovary, and it was traditionally thought to be of uh, uh, poor survival. But with recent advances and also with the multidisciplinary approach and advanced technologies in the post-operative management too, and these patients now are having a better outcomes. And for in future, it's better always to go with the tumor board discussions and assess the patient preoperatively and prepare the patient for the advanced surgery and for the better post-operative guided management too. And there are also this the role of genetic testing also has to be mentioned from the start prior itself, and patients has to be educated and communicated well in during the every step of the management. And and regarding the the role of PARP inhibitors, the targeted therapies, there is so much of improvement happening in the recent years with the technologies, and also even with the platinum resistant diseases are also are having a better outcomes when the with the novel therapies with the mirvetuximab and folate receptor antagonists, and also with the MEK inhibitors. So targeting these pathways, when previously traditionally when the platinum resistant diseases and with the advanced CA125 high levels of cases were initially when thought to be of poor outcomes, but now recently they are have, found to have a better outcomes survival benefit compared to the traditional chemotherapies. So it should be of like teamwork and multidisciplinary approach has to be there. And
No, you are. Hello.
so,
Hello. Hello. Yeah. I think you have hit the right buttons in saying how important it is to work together.
yes.
Important thing is also understanding, like you said, genomics, understanding the resistance mechanism, why certain things may not work, and not to give those drugs. So first time right treatment, rather than giving drug and saying, oh, this did not work, beforehand only, if you know, it really not only it is obviously better treatment, more cost effective, and works better. I think that is the approach one has to take for us to really reach that point. Thank you.
Thank you.
So this is another case, similar case. Again, a patient with a chondrosarcoma. sarcoma, poor prognosis, how this patient with the BRCA1 positive tumor, how they did well for so many years. And this patient was on olaparib, like what you said, doctor, and how this patient continued to do well for several years and reduced from 2350 to near normal. And how, so again, showing one of the things we do is each such case are created in a bucket. So when a new patient comes through our AI system and all, we say, please recall who have been like this, whose genomics is like this. So if they are there, then we can give them the same treatment to get the same outcome. So going into the depth of the disease, understanding the disease and each patient, and giving the treatment which is likely to succeed, I think is the most important thing. Gone are the days when we say clinical trial shows 50% will respond, but still I'm going to give you the same treatment. We cannot. So this is the era of precision medicine. We have to think like that to really achieve the goal. On head and neck cancer, tremendous changes have taken place in head and neck cancer. Today we are on the verge of multidisciplinary clinic where we say even advanced cases we can control, get long-term remission, potentially even maybe a cure by looking at hot tumor, cold tumor, immunogenic, PDL1 positive. And rather than doing surgery, this is an outstanding case where an advanced tongue cancer went into complete remission. Post treatment, you'll see up there, the entire tongue lesion went away, normal, on immunotherapy with low dose chemotherapy. How we achieved this and then did limited surgery, cosmosis was better, less traumatic to the patient, and overall better survival. I think this is how I call it the art of managing cancer. Truly, managing cancer is an art. Each patient we see, we should see, is this patient like my mother, sister, brother, son, whatever it is? Can I treat them like that? What are the forces I have to put together? Multidisciplinary genomics. That is how we are able to get these phenomenal responses with these patients because of that. So, doctor, I will ask our surgeons. We have two surgeons here, but they are GI surgeons. But I will ask you the question. Dr. Parvaz, how important it is organ preservation today? In the past, we did massive surgeries. Today, what is the focus on? Is it targeted surgery, outcome, what do you think should be the way we take forward?
Sir, in the era of precision oncology, like organ preservation is a very big thing. Considering the GI aspect, we apply it in rectum, where the total neoadjuvant treatment has come up. So even then, the genomic profiling plays a very important role, where we have to find out what is the tumor mutational burden of the patient, and then is it MSI high or MSS. So based on that, there is a very good response to immunotherapy and chemotherapy in MSI high tumors. And then neoadjuvant immunotherapy is also coming up in a long way. Compared to other trials, like the OPERA trial have shown that we can get up to 50% rectum preservation by giving induction as well as consolidation chemotherapy with chemoradiation. So yes, it is coming in a big way. We should not think like APR is the only management in rectal cancer. We can offer low anterior section and ultra low anterior section with the like facilities which we have, the newer staplers, and if the patient has good continence, the only indication I would say where we are going for APR is when the patient doesn't have a good continence and the tumor is very low down. Otherwise, we can offer rectum preservation with a very good functional outcome, and even the LAR syndrome is less. Yeah.
So, doctor, what you're talking about is, Dr. Karan, you mentioned that people who used to get the colostomy bags in the past, because of the robotic surgery, they don't need anymore. You are able to do preservation of the organ, which is very important socially for patient quality of life. Can you elaborate on that, how important it is?
I'll just give an anecdotal thing which I had. So there was a patient from Burma. So he was advised APR, that is, he will have a permanent stoma. So he had just seen us on a video, and he had consulted
How
us.
old was the patient?
Sir, he must be early 40s.
Okay.
And he was a driver by profession. So he used to work at a guy's place who was a rich man in Burma, but he actually took care of this treatment for this particular driver. And he underwent robotic surgery, and we were able to preserve his rectum. He had already received total neoadjuvant treatment in Myanmar itself, but he came down all the way, and we could actually save his rectum. Another case was, which we had done last week, other robotic case, in which we did not make any stoma. So I was pretty, I was pretty sure with the anastomosis, with the special technique, that is firefly mode, in which we put ICG, and we can see the perfusion of the anastomosis.
Okay.
So for us, the dreaded complication is always an anastomotic leak. But with this special technique of firefly, we put ICG dye, and we can actually see the perfusion of the anastomosis, which gives me reassurance that this anastomosis is not going to leak. And that tells me that I don't need to make a stoma in this. So there was no diversion ileostomy which was made. And patient went home day 5. So most of these patients are going back
Went
home
home
early.
on day 5 with
Yeah.
no stoma,
No stoma.
the tumor removed,
Tumor removed
and
with
rectum functioning well,
rectum functioning well.
good organ preservation.
Yes, yes, yes. And most of these cases, I was astonished to know that the next day patient was asking me, "I'm feeling hungry. Please let me eat."
See,
So
that is quality of life.
yeah, yes, yes. So that can only be achieved with MIS. I'm not telling that only with laparoscopic surgeries or only with robotic surgeries we can achieve it. MIS includes both laparoscopic and robotic. The robotic is the most advanced form.
Correct.
And with this special thing which I told, the ICG mode, it makes me really clear in my mind that I don't need to make a stoma.
And we have that robotic here.
Yes.
In our
We have the
center.
robotic, and for the medical legal part as well, if someone asks me why didn't you make a stoma, we have video evidence with perfusion showing in that there was actually a good perfusion. Why do you need
Believe
to
me,
make stoma?
nobody will ask you.
Yes,
Everybody
but
knows.
I always think about the medical legal part.
Why didn't you give me a bag? Nobody will ask
Yes,
you.
yes, yes.
Okay, I think it's a phenomenal. Similarly, it has happened in head and neck cancer.
Yes,
We don't
yes.
do laryngectomies anymore. Coming to the breast cancer, Dr. Jyoti Gupta. We have gone through the age of radical mastectomies. People used to say, even when we started HCG, or what to do. This lady from village, because she's a villager, I can chop off the breast. This was the attitude. So lower socioeconomic means it's okay, they can sacrifice. What happens? How does the husband treat her? Nobody bothered. When we did a study on 400 patients, 70% said the women were rejected by their husbands sexually because of the mastectomies. And nobody bothered, no surgeon bothered about it. They said, chop off. That is easy to chop it off. No? Easy to do. And difficult to preserve a cosmesis of the breast and do and get the same outcome. Can you comment on that?
Sir, hello. Yeah. So in earlier days, there was a concept of Halstead radical mastectomy. So in radical mastectomy, what they did was they removed the entire breast, they removed the muscle underneath the breast, the pectoralis muscle, the whole of axillary lymph nodes, and it was a very mutilating surgery. Very mutilating.
Mutilating surgery, correct.
Very mutilating surgery, and breast being a very feminine organ, it would leave a very bad and in fact even sad psychosocial outcome on the women as well. So then, why was it done? Because previously it was thought that breast cancer is a very centrifugal disease. It just follows in a circulating manner. It would eventually involve all the organs around. That's why such mutilating surgeries were performed. Now, in the year 1976, 77, I don't exactly remember.
77, big trial was done.
Yes.
Swedish trial, 7,000 patients.
The NSABP 06 trial was done by Professor Fisher, Dr. Fisher, he did the trial. Now, in that, as we all are practicing evidence based medicine, so we just cannot
But why
not
do we
view
still
this.
do mastectomies? Even
Sorry?
yesterday, somebody in Vijayawada, in our clinic,
Yes.
did a radical. Why do we still do? What is the reason surgeons still
The
do mastectomy?
reason was again another evidence-based trial, the Milan trial. So there was two groups, one for mastectomy, the second being only the tumor removal and radiation. The overall survival, disease-free survival, and the local recurrence is only comparable when this radiation involved with BCS, that is
Of course,
breast
everybody will
conservation
get
surgery.
radiation.
So now there's so many women who refuse, who live in villages, they refuse to come for radiation. So what is the
But I
take?
think when as a doctor, when they come to you,
Yeah,
I think you should do what is the right treatment, what not what the patient wants.
right. That
So
is
it
what
is
we are coming
important.
to.
We have to counsel them. We have to make sure. And nowadays, I think the acceptance is very high because they get neoadjuvant therapy, this radiation. So we need to push on that path. We
Exactly,
cannot
sir.
really say, okay, the patient wants mastectomy, I will do. I think 8, 10 years ago, HCG that was common in tier 2, tier 3 cities. What to do, the patient wants. The patient didn't come to you, they came to you for your expertise. So you have to do what is right. So this is
Exactly.
where we have to change.
That is where the expertise come, and that is where a proper counseling comes.
Yes. It is important. Patient counseling. Yeah.
Most important thing is that you will catch hold of the people who are doing MRMs, so
Pardon?
that you will catch hold of the people who are doing MRMs.
Yes.
So that is something is HCG exclusive. So and I know we are for BCS, but sir, sometimes it becomes really dicey to do BCS. Sometimes in T4B lesions, when skin is
Yeah,
extensively involved.
multicentric origin,
Yes.
this thing. But
Yes.
they have to go before the committee,
Yes.
the breast
Yes.
committee, tell them why you are doing and document it.
And you are very particular, sir. In MDTs, you are catching hold of each and every person who is doing
Absolutely, absolutely.
mastectomies.
I think, and also, Dr. Jyoti, with the integrated approach in breast cancer management, when the patient needs neoadjuvant, because normally the perception is, if I go to surgeon want to use the scalpel first. So I think that has changed, no? So how has it changed in the team? Can you explain that?
So, sir, initially, what used to happen, I'm talking about from the patient's perspective. They used to
They come to
come.
the surgeon first, right? Yeah.
Yeah. So they used to come, they used to get the diagnosis of cancer, they used to feel life finish. I just want to live a few more years. But now the approach has really changed. So we have a MDT decision based on the tumor biology, the tumor type, the tumor size. The decision is taken whether to go for neoadjuvant or to do upfront surgeries. So, like TNBC's tumors, we would always go for neoadjuvant first. No matter, even if the tumor is as small as 3 centimeters, still neoadjuvant first. So, that's how the protocol has changed these days.
So it is, with this, our outcome, which was a Harvard study, showed 90% disease-free survival, close to 10 years, on majority of the breast cancer, even triple negative doing good for 80%, equal to MDR. So data collection is important. Any center which treats cancer should have the data to back it up. Without data, particularly in Indian scenario, Indian genomics is different. We have to do that backup. While I will try to complete with the panel because I have some more slides to show. One of the things, Dr. Gaurav, as a uro-oncologist with robotic surgery, how has the robotic prostatectomy, how has this game changed? How is it work with radiation also? What are the advances in prostate? Because prostate is a chronic disease now. So can you elaborate on that?
So per se, for a prostate, at the outset, there's no difference between radiation versus surgery. And yes, a robot is a game
You
changer.
should talk to Dr. Raghunath on that. Okay.
And yes, a robot is a game changer. It's like a surgical strike. You go in, you take out the organ precisely without causing any collateral damage, and you're out. The patient is walking on day 1, he's home on day 3. Compare this to the time when it was an open surgery, the patient would be in severe pain, having a big scar on his abdomen, staying in hospital for 5 to 7 days, and margins positive at the end of it from the
Is it
pathologist.
most of the time, is it nerve sparing? Suppose he's a 55-year-old patient, 65, sexually active. What happens after robotic surgery?
The aim is always nerve sparing unless contraindicated by the disease. If
What are
there
the
is disease,
contraindication?
if the disease is extending beyond the prostate to involve one side neurovascular bundle, we cannot save the nerve on that side. We risk saving disease inside the patient. Ultimately, we are dealing with cancer. If we are
But
going
in
for
those
surgery,
cases, will the patient require post-op radiation too?
not necessary, sir. Not necessary. Again, the indications for post-operative radiation have now changed from adjuvant, that is immediately after surgery, to salvage, that is there are PSA cutoffs. In
What about
fact,
hormone therapy?
I'll just add, sir, in fact, even if margins are positive nowadays, many patients don't need radiation for about a year or 2 years as well.
Okay.
And hormone therapy is given as an adjunct along with the radiotherapy, as and when started. And upfront hormone therapy before going for a surgery or a surgical approach is still not the standard of care.
So, prostate cancer, when I was practicing in US, is one of the most common cancer. In India, it has not been that common, but it is picking up now. Whereas in Africa, we find it is very common. Our African patients, 40, 45, they get. So it is truly not a easy cancer, but sometimes surveillance is there. If the Gleason score is low, sometimes you do. It has always been a difference between radiation, surgery, robotic surgery, this. But the most important thing is the outcome is good, but the most important thing again is quality of life. If a person is sexually active so many times per week or whatever it is, can they be the same post? And that is a debate, right? Which
Absolutely,
happens
sir.
all the time, and
Absolutely.
nobody can guarantee whether that will happen. Even with the nerve sparing, I find patients have problems, right?
Yes. There's nobody can guarantee either we give them surgery or even if we irradiate that area.
So
And
one of the recently it happened to me on a lighter note. One of the patients, the surgeon said, "I'm doing a not nerve sparing surgery. I'm going to remove." He's 65. I said, "Why are you remove?" Uh, I think he has no sexual activity. I'm going to. I asked the patient. He said, "I'm very active. Why are you going to do it?" So, giving them counseling, going to the depth, I think it's so important. Quality of life, see the mental status of the patient post-operatively. That psychology is something we lack in India. Counseling, psycho-oncology. We have a large team of psycho-oncologists. We want to expand it, but that is something we lack in Indian scenario, and that is something I think we have to take up seriously. Dr. Arjit Binchu, we have not discussed much about hematology, oncology, but in your view, what are the major advances in this field? And can you briefly tell where you see leukemias, lymphomas, which were considered very difficult diseases to treat? The days of CAR T, HCG is going into CAR T. We are going to be a manufacturing unit. How this is going to be a game changer for you? We have done some CAR T therapies here in Calcutta. So where do you see the future?
So as already have been discussing that uh, right now we cannot be only followers. Sometimes we need to be leaders, and we have to curate treatments. That is one treatment for one patient. It cannot be an umbrella treatment for all of them as a same as all of it. Uh, with time, our therapies have evolved. Earlier, it was targeted only to cure the disease. Now, the target is not only to cure the disease, but along with it, preservation of life, preservation of quality of life, and quick return to normal life. That is one of the major goals of treatment, with an idea that the cancer does not return back. So over this period of time, slowly we have started going away with from the conventional chemotherapies. We have moved into immunotherapies. Now slowly we are going into more targeted therapies, and now we are coming across cellular therapies like CAR T cell therapy, or uh, fine tuning the transplant procedures that we have been conventionally doing over the years, like with mediums like the Clinimax that we have. at our center. And over time, there would be a time when CAR T-cell therapy would be available off the shelf. That is where we are looking forward. So it is a cellular therapy. Right now, the major hindrance to CAR T-cell therapy is the production. The CAR
That is all
T-cell
going
takes,
to ease in the next 6 months for HCG. We'll be producing it.
yeah, but production is still a time-consuming matter, because you have to keep the patient off therapy or bridge the patient with something till the time the CAR T comes ready. So in the near future, maybe we'll have a time when CAR T cells will be available off the shelf, which are called the allocars.
Correct.
Where I can tell this is my patient and he has this HLA group. I need this HLA group allocars, and this time of to wait will be gone, with reduction in mortality and improvement in
And even the
outcomes.
cost will come down.
Cost will come down. And the second advancement that may be in the near, very soon, which will come towards, because with the early and more improved knowledge of the cellular system of the body, the tumor biology, we are going ahead with NK cells, which does not need any antigenic stimulation to get activated, which will be more safer, which will remain in the body for long, and which will control the cancer for a longer period of time. And I will use an example to say what I've been telling now. So last year, to 2024, we had a patient who was almost 65 years of age. He had a primary CNS lymphoma. He had received all kinds of therapies, conventional therapies, including temozolomide, methotrexate, lumbar punctures, everything, but there was no reduction in the size of the tumor. And at one point of time, all the clinicians had folded their hands at this point of time. There is no way to cure it. So when he came to us, the idea was to go ahead with the conventional therapies. That is, you give high-dose chemotherapy followed by an autologous stem cell transplant. But this patient had received so much of therapy, and because of his age and other comorbidities, he was not in a position to receive any more chemotherapies to go ahead with this kind of a treatment. So we had to be a little innovative to how we can treat this patient. So first, understanding the biology was important. So we evaluated him properly, got a repeat biopsy, got a CSF study, got all the molecular data, got all the cytogenetic data, the tumor markers, whichever was possible, we did it. And then we curated a plan that will treat him with a CD20 antibodies. Now, CD20 antibodies currently, which is available in India, that is rituximab, does not cross the blood-brain barrier.
Yeah.
So how do you deal with it? So we got glofitamab, which is a CD20, CD3 bispecific antibody, and which is a very good penetration to the brain. So that was the first step. We knew we could control the tumor. The second step was how to control it in a way so that it does not come back. So the next step was went ahead with CAR T-cell therapy. Now, CAR T-cell, again, as I told, it takes time to be produced. So we needed to keep the patient with decreased tumor load for that period of time. So then we combined radiotherapy, which is not the standard second-line treatment. Usually radiotherapies, whole brain RTs are used kind of palliation, that is the end of life scenario. But we combined radiotherapies as a bridging therapy. We gave glofitamab and then did a CAR T-cell therapy. Now the next question was that this patient do not have a second attempt. If his cancer comes back, we may not be able to salvage him the next time. So the next question was how to keep the CAR T-cell alive in his body. So as I told, we had done a good amount. We had good amount of data. So the tumor had PD-L1 expression. So we used the PD-L1 inhibitors in that patient, which also had a dual effect on expanding the CAR T. And now, over a period of almost more than 1 year now, he is doing absolutely fine. And the good part is he went back to his normal life much earlier than what he have done after an autologous stem cell transplant.
Thanks, doctor. What you have elaborated is truly the art of managing the cancer. So, step by step. In this regard, doctor, we have our radiation oncologist, Dr. Abhijit Das. Dr. Das, art of managing radiation historically did not have a good, because there was normal tissue, there was we came with targeted, We used to give radiation for 6 weeks, 5 weeks, and it was patients say, how can I come along? Now the dynamics have changed. Hypofractionation, precision radiation, quality, cosmosis. So you tell me now we no longer treat, rarely we treat whole brain. So what is the essence of this art of managing with radiation, and how does this really benefit cognitive sense for the patients? How the quality of, because you may live 1 year, you may live 5 years, but how you live is also important. Okay, so can you briefly elaborate on that?
Yes, sir. As an
And
radiation,
what do we do here in Calcutta? What type of technology we have to achieve that?
sir, as an radiation oncologist, we are actually everywhere. We actually treat almost every sites. Uh, for the brain mets, the most important that previously we used to treat a whole brain RT, and as we all know, there is a quality of life decline. Nowadays, with a more and more era of immunotherapy comes, more and more of NGS coming, we know what will be the better systemic treatment. We can determine that. And on the top of that, if we can actually localize the metastasis more and we can give a very specific radiation to that site only instead of the entire brain, so definitely cognitive decline will be less. So in that way, we actually, again, it's a matter of MDT, so that what will be the sequence and what will be the sequence of the systemic therapy and the SBRT or SRS. And by that, we can actually not only prolong the life of the patient, also we can take care of the quality of life. That is very much important while talking about the cancer care. We have tomotherapy and the elective Versa HD, which is both are capable of treating SBRT and the SRS. We are routinely doing it also. Just like that, today we have done a scan for the acoustic neuroma. And beyond that, previously what is happening that we tend to use a bigger amount of dose in more number of fractions, but slowly we are going towards the hyperfractionation. That is because of the development in the knowledge of more TCP and the NTCP data, by which we know that alpha beta, whatever we are thinking routinely as a 10 for every acutely acting tissues, reacting tissue. Instead, we are now considering that okay, the breast has actually a higher alpha by beta, lower alpha by beta, by which we can do a hyperfractionation. So slowly, I think, sir, in this era of NGS, radiogenomics, radiomics, we have a lot of space to grow. And beside that, we have technology aside us. And by the help of technology, we can do more precise treatment, and obviously the outcome will be better. We are already seeing it actually, sir. We are witnessing it.
Say, in my view, the art of managing is, you see a tongue cancer like this, you do radiation, or you do a breast cancer radiation surgery, the patient's spouse or the doctor, whoever patient, should stand in front of the mirror. They should know which side was treated. Cannot make out. That is truly managing art of cancer. And no trismus, nothing, no dryness of the mouth. And that is where HCG comes in. We audit how many patients, what type of fibrosis happened. Breast cancer used to be arm edema. Those are all olden days. We have to now see, fibrosis of the neck. All of this is not acceptable. And that is high quality. It is not only how long you live, but how you live. Both are equally important. And that is the logo of HCG. It is the quality of life. So I will take you through a few cases in my conclusion. And this is again a very rare syndrome for Bloom syndrome. How we recognize this, how we have treated this patient, extremely sensitive to chemotherapy because of the Bloom syndrome. Any small, if we had given normal dose, the patient would have died with neutropenia sepsis. But how we manage low dose weekly, checking the MRI weekly, and one of the things we have is we check often. And by the way, when we do that often, we don't charge the patient. We, one time, first time maybe towards the end, but we make sure it is our interest to see how it does. So all of these kind of protocols have made a huge difference in the outcome of this patient. This again is a patient of breast malignancy, metastasis, TNBC, which is a triple negative. How this patient has done extraordinarily well for 4.5 years coming up on, and remarkably done well. And she is on metronomic therapy now, and how the thing happened. This is a child with infantile fibrosarcoma, 28 day. This is an interesting case where the patient went all over the world and was told requires amputation. And finally, they came to Dr. Pramod, who is ortho surgeon. Remarkable he did was preserve the limb. I saw the baby about a month ago. The baby is growing, the limb was growing, and the tumor is not there. And we have put her on a targeted therapy. We are helping. It costs about 2 lakhs a month. We are helping them financially through the foundation. All I want to say is what was an amputation was prevented, organ preservation. This can be done only in centers of excellence. This kind of coming together, what anesthesia you give, how long you take for surgery. So having been in US for a long time and come here, I can tell you clearly, India may not be an advanced country in all aspects, but in oncology management, in HCGs, truly it is an advanced country. It is even maybe better than advanced country in the outcomes we have. And that is what we take pride in, like how we embolize, how we do, how we prevent local recurrences. This is to show what I said, mortality. How the mortality, by just auditing, how it has come down from 3.4. Everybody said cancer, 3.4 is accepted. Even multi-speciality, 3 below 5. I said no, we have brought it down below 1%, 0.7% in January. 0.7, 13,000 discharges. So it speaks for how by just personalizing, focused factory approach, we can achieve these goals. And this thanks to Dr. Bhattacharya and team. Monthly we audit, we have a major team in this. So these are all some of the things, understanding cancer. We know cancer burden is going to increase in the country because of certain things, smoking. When I told the parliamentary committee we should ban smoking, one of the parliament members said, Doctor, really smoking causes cancer? Does it really cause? So I said, if you ask me that question, what can I answer? So that is, and then when I went to the Niti Ayog, went to the finance minister, said, this is such harm. 40% of cancers will come down. The answer was, there's a big revenue for us. At least the sin tax what they have, they can devote it to preventive medicine and all, which they have not done. And in this regard, HCG has taken some leadership role to develop alternate farming. In a Karnataka, in a tobacco belt area, almost 100 farmers as a pilot project, we have converted them from tobacco growers to non-tobacco and cash crops, and they're doing well. So we will contribute, but unless we come up with a plan, pesticides, herbicides, almost 20 patients breast cancer, suppose they come with right side, we have checked with mass spectroscopy on the left side, on the fatty tissue. What is they almost all of them have degraded products of pesticides. What does that tell us? Chronic inflammation is the most common cause of cancer. Obesity is the commonest cause of cancer. Why obesity? Because these products go and settle down in the fatty tissue. When a woman takes food which is not organic, breast tissue is one of the areas where it goes and settles down. As it settles down, it causes chronic inflammation over decades, leads to cancer. By eradicating pesticides, we can. I am preparing a public interest litigation to see whether at least we'll create awareness that this kind, based on the data we have, that we should ban pesticides or restrict it. We have to do that if we have to overcome the burden of cancer. In India, it is now going to be 1 in 7 or 1 in 8. All of us have friends, relatives with cancer. So obviously, it is increasing dramatically. We have to look at is how we can overcome this problem. I have a lot of slides, but I will just skim through to show. One of the things is how treatment plan, proper accuracy, patient-centric makes a huge difference. This is how evolution of technology has taken place. Digital pathology, precision medicine, adaptive therapy, cyber knife, molecular genomics. I'll show some slides on that. Huge improvements have happened in a country like India. We are on par with the most of the advanced countries, even MD Anderson. But we need to really bring about certain changes in affordability and accessibility. Otherwise, we will certainly not show improvement. And we have so many cases we see, and we have a center in Kenya, And we, as you can see here, oncology chain, we have significant number, 25, some at 400 oncologists, largest network in the country. I am very proud that we have such dedicated doctors, but still lot of work to be done. And we look upon HCG as a destination. What does it mean? Nobody can do anything HCG can do. I think that is what a destination is. Research, treatment, technology, everything we have today in terms of things. As I said, I'm establishing CAR-T lab, organoid lab, data scientists, academic scholars. We have nearly 250 fellows programs in HCG. We are taking it forward. We have an institution, IRC research committee. We meet once in 15 days. We have 10 crores to spend on it and see how we can spend, what are the programs we can do, how we can encourage youngsters. This is the Harvard study showing that how our outcome in 2013, it may be even better now, is equal to the best of centers in the world. This is about the MD Anderson versus us. As you can see here, HCG is equally good or even maybe better in outcome in TNBC some time ago. So it clearly shows we are very capable. We have excellent doctors. We have to pat ourselves on back. As you know, when you go abroad to any areas, whether to England or US, Sloan Kettering, you see mostly Indian doctors. And others, maybe we are not getting the name, but we are there. We also run major companies like Microsoft, Adobe, Google. We are very capable people. But why is it not happening in India? Why are we not? That is the mystery. And that is what we have to unclog and make sure we become leaders. Head and neck cancer is 38%. So recently, we are about to tie up with Ashoka University to create together, we become center of excellence for head and neck cancer. We do deep research, we go into that and see how this cancer can be treated properly, right way, first time. And truly with that, we can become global leaders in managing head and neck cancer. I hope cost is always a factor, but we have to consider outcomes. Cost with outcomes. Without outcome, what is the cost? I can do anything cheap, but the outcome is not good. So we have to measure that. That is what is value-based medicine. And it is precision in pathology and fundamental changes. We all see digital pathology. In our tumor board, every patient we see digital pathology. Is it a hot tumor, cold tumor? Or is it the right treatment? We see the PET scan. So essentially, it is very important how we use AI also, create algorithms. So I'm rushing through this to show how complicated it is. For India, for example, our global data, hot tumors are 61, PDL1 positive 78%. You know, but very few are getting immunotherapy in head and neck. Why? Even low dose immunotherapy we have mastered. What used to cost 1,25,000, today we can do it at 35,000-40,000 by low dose and getting equally response. Of course, pharma companies don't like it, but that is the truth, that they get good response. We don't need to give full dose. So with these things, we are pioneering the efforts, how we practice currently, how, like doctor mentioned, NK cells, this, we have a, iCrest, all of this will come into play for us as we move forward. And this is the type of tilts we get in HCG compared to the global data, showing that some of the anomalies are there between the two, but majority of them, we have a lot of work to do to achieve our good outcome. And Indian genomics is different from Caucasian genomics. That also we have to keep in mind to see what is the right treatment to do. Head and neck is the most important thing for us because it affects all sections of the society. We have to go in terms of see the PDL1 positive in head and neck, 78%. That means 78% can get immunotherapy and truly benefit. They may not need radical surgeries. They may not need radical things. Immunotherapy, limited surgery, radiation can be potentially curable and cost effective also to prevent recurrence. Obviously, when recurrence happens, there is cost. So how do we do this? So these are things we are taken up. I won't go into the details of all this except I have one slide, recurrent cases, how we follow. You can see here, head and neck number. Across HCG is audited. Any recurrence, we will know. Why it happened, the doctor has to explain. Or what is the learning curve? So that is the level of accuracy, precision we have gone. And then, I will just end this with one progress precision medicine. I said it is for us. It is not just patient-centric, specific to the person. And just genomic data I want to show. We are one of the largest in the world. 2,000 complete sequencing we have done. Every month we are doing 100. And this data is a game changer. Here you see that nearly patients with actionable genetic alterations, 74%. 68% with druggable genetic alterations, and 69% change of therapy. That means 69% we are going to give wrong approach. With the genetics, we are giving different treatment. So it is important to understand all this. So first time right treatment comes about. And this is again spatial genomics, which I mentioned, how heterogeneity of the tumor is there. And with all this, there are a lot of things we are doing. And how do we measure resistance? So you can see here, when you give endocrine therapy for breast cancer, what is the resistance mechanism? Who we should not give? I mentioned about PIK3. 33% of PIK3. So that this is resistant to endocrine, resistant sort of. They should not get. Maybe we have to give them CDK4 along with it. So these are some of the things how we can identify. I'm just giving you a sample of how we should practice medicine today in lung cancer, prostate cancer, and proteomics is an important thing which is coming up. I mentioned to you about proteomics. We have got a huge equipment. We spent nearly 20 crores to bring this equipment to identify who we should treat based on the proteomics. So a deeper understanding of cancer biology is important. What is happening, how cancer challenges you is relentless. And we have to be relentless in order to win the war on. This to say, oh, cancer recurred. That is not acceptable anymore. We should not accept as a society, as a patient or as a practicing cancer specialist. We should not accept. We should do the right treatment first time. So many things are happening, liquid biopsy and all. We have a big biorepository, 500,000, 500,000 biorepository. We are working on that to see how we can take it forward. And I think RT I mentioned, I will, this is the bucketing. This is one of the last slides to show how we should bucket A, B, C, D, E, up to Z it will go. Maybe beyond that, which patient belong to which bucket. That is what we are doing, collecting data so that future patients will get the right treatment, and future is now. Patient coming in should get the right treatment. How many patients like this I have treated? Which category they belong? Let us treat them like that. So get the best of outcome. So it is common sense, and unfortunately, as one of the great philosophers, Voltaire, said, common sense is so uncommon. In oncology, I think we should use common sense, use our knowledge, simplicity in complexity. Complex situation should be brought down to simplicity and say, what is the right treatment? It's a book I have written called Excellence Has No Borders, clearly showing, doesn't matter where you are, excellence is the key to achieve our goal. With this few words, I will end my talk. And thank you for being very patient and listen to me. I also thank the panelists. You all actively participated. I don't know any one of you have any final comments. You are welcome to make.
Hello, sure.
Okay. If not, I will conclude, and thanks again for being here. Thank you.
Thank you so much, sir, and thank you so much, all the panelists. Please a big round of applause for them. Ajay sir, you stay there. And okay, and now we are open for the Q&A session. So if you have any question, you can feel free
They
to
can
ask.
sit here also, pan, if they want. I think they can sit here if there is any Q&A. If you guys want to sit, okay.
Okay, mic is there.
Come, doctor. You know, there is any Q&A questions? None of them can come and sit. You be here with me. If there is any Q&A, I'll ask you also. Okay. Yeah, any questions? Okay. I don't know.
Anyone?
Okay. There are no questions. I hope we were very clear. And once again, thank you very much. Thank you
I
very
think
much.
everybody's hungry. Sir.
Everybody's hungry. Ready for cocktail? Okay, I got it. It's 9:30. I think we are pretty much done close to 5 minutes ahead of 5 minutes more than the time we took, 9:40. Thank you very much. Thanks. Manish, you want to say anything?
Ajay, so please stay there because thank you, all of you. Thank you so much.
Thanks.
And may I request Mr. Gurvinder Singh to felicitate Dr. Ajay
Why
Kumar?
facilitate? I'm part of HCG.
Please, sir.
No.
Please, sir.
No, it's just give me 5 minutes. It's good.
Please,
Thanks.
everybody, a big round of applause for him.
Just give it to my
What a
hand.
insightful
That's okay.
session it
Give
was.
it to my hand. Yeah, good.
Thank you so much. So please stay there, and may I request you to join Dr. Manish Mattu, please. A big round of applause to felicitate Dr. Thank you so much. And may I call on stage Dr. Rupali Basu. Please, everybody, big round of applause to welcome her.
I hope so.
Thank you, Gurvinder sir. Thank you, Gurvinder sir. And you three people, please stay there. Because we have the poster and we commit to decoding the future where the technology and the empathy you need to transform the patient outcomes and redefine the cancer care. Can I have all the poster, please?
Manish,
Manish sir, please again join with us.
what are we doing? Okay.
Decoding the future of cancer care, we commit to decoding a future where the technology and the empathy unite to transform the patient outcomes and redefine cancer care. A big round of applause, everyone. Thank you. And now, time for the group photo session. And for that, I will like to request all the ACG staff to come on the stage for the group photo session. And ma'am, meanwhile, I requested to vote of thanks for all people who are being there. Okay. All the ACG staffs, please come for the group photo sessions.
And please show the victory tours to the camera. Everybody, show them. Enjoy. Everyone. Yes. And a big round of applause, everybody. Come on. And this is to inform you all that we will shortly open the bar after the vote of thanks. And may I request Rupali ma'am for the vote of thanks.
What an evening it has been. Can we have a round of applause for all of us, from all of you? As we come to the close of this enriching CME, Decoding the Future of Cancer Care, I would like to take a moment to reflect on what we have experienced today. We began this evening with a powerful reminder that cancer care is no longer just about treating disease, but about understanding biology, leveraging data, embracing technology, involving in continuous research, innovation, academics, and most importantly, delivering the right treatment at the first time. On behalf of the entire HCG family, it's my privilege to thank our founder chairman, Dr. B.S. Ajaikumar. Can we have a round of applause for sir? For an exceptional and deeply thought-provoking session, sir. Your vision of integrating genomics, technology, outcomes, compassionate care continues to guide us, continues to guide not just HCG, but the future of oncology in India and abroad. Your insights today have once again inspired all of us to think beyond the present and work towards meaningful, measurable patient outcomes. I would also like to thank Dr. Manish Mattu, our Executive Director and CEO, for setting in context so beautifully, for his continued leadership in strengthening the HCG network and expanding the high-quality cancer care across regions. A special thank you from for all of our esteemed delegates and our clinical leaders. Can we have the loudest round of applause for all our doctors? For the engaging, honest discussion, your perspective highlighted how multidisciplinary collaborations is no longer optional but essential if we are to deliver comprehensive and personalized cancer care. I would like to extend my sincere gratitude to everyone who joined us today. Kolkata team, corporate team leaders, your work, presence today, questions, participation made this CME truly interactive and meaningful. Continuous medical education such as this helps us collectively raise the bar of oncology care in the Eastern region and beyond. Can we have one more round of applause for all of us? Thank you. Thank you so much. As we move forward, let us carry today's learning with us to question more, to collaborate better, to adopt innovation responsibly, and most importantly, keep the patient at the center of every decision that we make. Thank you once again for being a part of this evening. I wish you a pleasant time ahead during dinner, cocktails, and look forward to continued engagement and collaboration. Thank you. Thank you all. Wonderful evening. Thank you.
Thank you so much, ma'am. Now it's time to unwind and content dinner and cocktail. So everybody enjoy. Good night, everyone. This is Ajaikumar signing off. Thank you.